Rhinosporidiosis. It is a chronic granulomatous disease caused by Rhinosporidium seaberi, which belong to class Mesomycetozoea. Mesomycetozoea are new group of microorganisms which lie in between fungi and animals and are usually parasites of fish and other animals. This disease is endemic in India, Sri Lanka and Africa. Mode of transmission. 1. By bathing in stagnant ponds in which animals also bathe. 2. Autoinoculation. Rare. 3. Hematogenous spread. Rare. Clinical features. Depends on the site of involvement. The lesions are usually seen in nasal cavity and nasopharynx. These are reddish polypoidal, bulky, friable mucosal masses. Conjunctiva, mouth, larynx, genitalia and skin are the other rare sites of involvement. In the nasal cavity, the lesions begin as sessile masses and they gradually grow to become fleshy pedunculated polypoid mass. History. Unilateral nasal obstruction. Epistaxis. Local pruritus. Rhinorrhea. Coryza rhinitis with sneezing. Post-nasal discharge with cough. Foreign body sensation. History of exposure to contaminated water. Increased tearing and photophobia in cases of infection of palpebral conjunctiva. On examination. Pink to deep red polyps. Strawberry-like appearance. Bleeds easily upon manipulation. Gross. These are reddish polypoidal, bulky, friable mucosal masses. Microscopy. Has characteristic morphology. Sporangia of various sizes are located in the stroma of the polyp. The overlying mucosa may show squamous metaplastic changes. The largest of these are usually immediate subepithelial in location, which may or may not show evidence of rupture. Mature sporangia are 100 to 450 micrometer in diameter with a thick chitinous wall and contain sporangospores in different stages of development. Sporangiospores stain basophilic and measures 7 to 9 microns in diameter. If there is rupture of sporangia in the stroma, an intense granulomatous response can be seen. The stroma is comprised of moderate to abundant chronic inflammatory cell infiltrates made of lymphocytes, plasma cells and macrophages. Surgical excision with cauterization of the base is the treatment of choice. Histopathological examination of the resected specimen will confirm the diagnosis of rhinosporidiosis. Histopathology of rhinosporidiosis shows thick-walled sporangia in the submucosa varying from 10 to 200 m in size, containing sporangiospores. Earliest stage is thin-walled juvenile sporangia 15–40 micrometers, which develop into immature, intermediate and mature sporangia, accompanied by changes in the thickness and lamination of the walls and appearance of nuclei around which cytoplasm condenses to form endospores. Several hundreds of endospores are embedded in a mucoid matrix. The mature endospores contain up to about 20 spherical 1 to 3 m electron dense bodies, which are considered as proteinaceous, nutritive reserves and precursor of trophocytes. Each mature sporangium contains an operculum or pore, through which endospores are extruded. The stroma is fibromyxomatous and contains lymphocytes and macrophages, while neutrophils are numerous around. Medical treatment is not so effective, but treatment with a year-long course of dapsone has been reported.